Hello and welcome back to the Out of Program podcast. Today we're joined by Dr. Rishi Das-Gupta, a doctor and health system leader and also the Chief Executive of Health Innovation Network, South London. He's held numerous senior leadership roles across the NHS and has worked for both McKinsey and Oliver Wyman, leading large-scale operational technology and innovation transformation across UK and US healthcare systems. Hello, Rishi. Welcome to the show.
Hi, Jing. Lovely to join you and very keen to have the conversation this morning.
So let's dive straight in, starting with your early career. What drew you to medicine and what were those early years like for you as a junior doctor?
So as with many people who join medicine, it was sort of a mixture of really enjoying science, but also loving interacting with people. And so medicine was a natural career move. And of course, as with many people, I knew lots of doctors along the way. And so I had a good sense of what I was letting myself in for, or so I thought. And then the first couple of years, some of your older listeners and will remember that, the contracts and hours were quite intense and quite long at the beginning. There was a period, I think through the 80s, before I was working, when the job became more intense because people had focused on productivity for a while. And whereas for my parents' generation, people might have been working a 1 in 4 on call and covering 3 or 4 wards, by the time I'd started working, we were doing a 1 in 4 on call. So every 4th night on call, as well as the days, and covering the whole hospital. So you got very little time to rest. And so the lifestyle at the time was you started work at 9, you worked overnight till the next day, you were pretty tired. The next evening you kind of recovered, and the night before you started this shift, you didn't go out late that evening. So I think it was a level of intensity and commitment that was probably more intense than now. But one of the things that as the BMA at the time we were trying to do was to focus on how to make lifestyle work for junior doctors, and thinking about the hours was the key bit that was part of that negotiation back in the early 2000s. My involvement was on the implementation side, actually, and I've always found implementation quite interesting because when you actually try and make a change happen, the bit that often is difficult to manage is the bit on the ground and the unforeseen consequences. And so I was involved on the South Coast as the local implementation at the time. And it was really interesting. So I got involved in, what does it mean to move to a shift pattern? What does that mean for things like handovers? And I hadn't been taught as a student how to do a really good structured handover to another person taking over from me at the end of a shift, whereas nurses did that all the time. So that was part of their training, and it may seem strange to doctors who've qualified since then, because I think it is now included as part of the training. Has that been your experience, Jing?
Yeah, I mean, yes, absolutely. I think that a lot of these things are kind of underappreciated, but it's really relevant. I wanted to touch a bit more on what you on that experience with the BMA that you just mentioned. What was the motivation for getting involved, during your time as a junior doctor?
That's really interesting. So I'd like to make it sound like it was a really thought through decision, but there's all those comedy movie moments where you ask for a volunteer and somebody sort of doesn't step back quickly enough. And I think I was probably in that camp more than anything else. It was something I was interested in. It was something that somebody had to do. We all knew that somebody had to do it. And I found it quite interesting. And when we went around the room, it's like nobody else seemed to. So I was happy to pick it up. Actually, I'm so glad that I did, because it's shaped the direction for my career since. And I think that I now have impact probably across more patients than I would have done as in clinical practice alone, because it's about how systems work and how we deliver at scale and how we deliver consistently, and particularly how that impacts patients from who have multiple health inequalities along the way, and what happens there.
Yeah, it's really interesting you say that because I think a recurring theme from the conversations we have on this podcast is that clinicians pursue roles where they can have a much greater system impact. There's of course a real enjoyment and value in seeing patients on a one-to-one basis, but in terms of making that impact at scale, I think that's often a driver for pursuing research or technology or policy, as you describe. And the other thing I found really interesting about what you just described is it really makes me reflect on a conversation I had recently with Johan Malawana, who was the chair of the Junior Doctors Committee back in the day in 2015, 2016 Junior Doctor contract negotiations. And he also had the responsibility thrust upon him. So what I tend to find when speaking to individuals who pursue BMA responsibilities is that it's a responsibility that seems to be thrust upon them rather than something that they actively pursue. Is that something that you found?
I think that's I think that's true, and it isn't something that I went out to pursue, but it certainly opened it opened my eyes to a whole series of problems that weren't obvious to me at the beginning, and in hindsight probably should have been to any of us, right? Which is that I think certainly for myself, I was quite focused on my own clinical practice, how the interaction with individual patients went. I think what I hadn't given as much thought to is, do I get satisfaction from making things happen at scale? And I'll be honest, when I was a med student, I did public health the way that it was taught at the university that I trained at. And I left going, I don't think that's for me. And I think the other bit that I've learned along the way is that there's often this kind of them and us situation where everyone assumes the other people are doing things that are just ridiculous and stupid. And I'm sure that happens in some places, but the majority of people are intelligent, well-meaning, trying to solve what they perceive to be the biggest problem at the time. It's just your perspective leads you to think that a different thing is a big problem. And so they're maybe solving something different. And so that's what I've taken away from it, is that feeling of, if I assume the other person, the other side of the table is really trying to do their best and do the right thing, how can I help them? And that's what I spend my time nowadays doing, which I get a lot of satisfaction out of. I did for a while do both things in parallel. And I know a lot of people do that. And that made it very easy to make certain transitions at different points. Where I think when you're always doing things next to each other, you can go, well, I'd be happy to do more of this and less of that. And does it really close any doors to stop for a little while?
I think that's a really interesting reflection because a lot of the guests we speak to talk about the desire to balance both the clinical practice and the work outside of that. But at some point, you do need to make the decision, or naturally the career takes you in a direction. And I guess those are some of the trade-offs that people often reflect on. But on that topic, I now want to move on to the next stage of your career, which is when you opted to move into consulting. So at some point, you of course made the leap into organizations like McKinsey. And I wanted to really explore, what your thinking was at the time. Like, how did you make the decision to leave clinical medicine at that point?
Yeah. So I had been working in hospitals on the South Coast for a little while at that point. And we'd been introduced to people from other industries. So people from aviation came to talk to us about safety, and people from operations at Toyota came to talk to us about lean and various pieces. I think that I from that took away that it might be interesting to go and see what's done outside healthcare in order to then come back. And at that time, it was quite difficult to do less than full-time training. So I think that's one of the things that has changed and improved since then. So
Definitely.
it's quite hard to juggle doing something outside clinical practice alongside doing something in clinical practice. I think my decision, the way I framed it was, do I want to take a year to 2 years out to go and see how things are done elsewhere? And what's my best way of getting experience in doing that? And obviously I did what anyone would do, which is go out and talk to a bunch of people who I knew who did different jobs and see what might suit me. And of that, what attracted me to consulting was the fact that you got to see a lot of different industries. So you went in to solve a problem. They often immersed you in that industry and in that organization. So, I got to go and work on site at a pub chain that ran 2,000 pubs and did it, different formats and different things along the way. And soak up what the culture is like there and see on the ground what processes they ran that were different, that made them successful in what they did. And in background, I was thinking, well, how do we apply that to healthcare? And so that was always intended to be a time-limited 2 years doing something else. And so I consciously went in and went, well, I don't want to do healthcare. And so they went, well, if you're not doing healthcare, we can't bring you in at the more senior level. You have to start at the more junior level with everybody else out of university. I went, okay, well, I can do that. And, work through that and did a generalist approach.
And what was the transition like? Because you were obviously clinically practicing, so that's one skill set. And I guess there's some transferable skills from your time at the BMA. But then in landing into an organization that is well known for being particularly intense, how did you find that baptism of fire? Like, was it challenging, or did you take to it quite easily?
I think I took to it fairly easy. There were probably 3 bits that I would reflect on. The first is you get really good feedback in consulting organizations. They're used to taking on people from different backgrounds and different industries. And I think most people come from university, straight from university, but actually I wasn't the only person joining from industry, and I wasn't the oldest, and there were a variety of different people. I think that also leads to something else that I appreciate in hindsight, which is that they were very good at managing diversity. Because at one level, they wanted everyone to work within a set of frameworks so that you pull together a team from around the world and put them to work on a problem. But on the other hand, the reason that they were bringing together people from around the world to work on a problem was that we might all have different perspectives on it. And so they were very good at handling that diversity and making... I certainly felt valued, because my opinion, saying, well, what do we think about this, is important. So that's the first thing I'd say. In terms of intensity, I described the hours in medicine at the time, and I think it was a comparable number of hours, actually. So I remember the first project I did, I don't think I left the office before midnight, and it was normally around 2. And we were starting again the next morning at 8. And it was an incredibly intense and quite difficult project. And, you take that in your stride, because we've done that along the way. And that's not a problem. But what I think one of the bits of feedback I got was, well, we're a bit worried that you're not totally invested in this, because you don't seem to be panicking about it. And I was like, well, nobody's dying, right? It's not like A&E, where there's the level of stress is high, but it's different, and it's self-imposed, and it's a different level. So I think thinking about careers in healthcare and elsewhere, there is a bit of a difference in the type of stress that's involved and how we perceive it. And at one level, I think you talk about transferable skills. I think there is also a you could always go back to medicine, couldn't you, if it didn't work out? So the level of stress, and I think, is easier to handle with that background. And then I think my third reflection on it is transferable skills. There's a lot of, they test for a bunch of skills in consulting, and they test all of that as you come in. But where I think, having qualified in medicine and practiced for a few years, I remember sitting down and thinking, well, in 3 years of med school and a few years of practice, we've talked to 10,000 people by that point in your career, had quite deep and intense conversations about what their lives are like and how things have affected them. And that is a set of experience that I think we we don't always value as highly as we should outside the healthcare industry. Because if you compare that to someone who's 21 and been through university, the number of people and the diversity of people they've talked to, it's quite different. So you then have to go and talk to the person on the ground who's responsible for moving pallets from one place to another. It's kind of understanding what their job involves and what questions would you ask them and what lots like in person. That's a set of skills that we should all value, that we've all built along the way, and that I think you take anywhere.
I think what's really interesting about what you've just described is that going into this experience, it seemed like you were very strategic and had a long-term plan, which was to spend some time in industry, gain a broad range of experiences, but ultimately come back into the healthcare system, which of course you ended up doing. But during that time, did you ever think, maybe I'll just stay in consulting? What's very in vogue at the moment is a lot of the clinicians will talk about their work, their experience in the front line, and talk about jumping ship into big four consultancies, very much with a view not to go back. But for yourself, your intention was to take those skills and bring it back into healthcare. So at any point, did you question that plan?
Oh, we should definitely talk about where my plan went wrong, right?
Oh, please, yeah.
Definitely. So I ended up spending 10 years doing consulting, not 2 years. I found it fascinating. So the first thing is I found that there was an area of consulting that I really enjoyed doing that not everybody enjoyed doing. And I always think it's useful to think through, how do you differ from your peers and colleagues, and what's your unique advantage in each of these things, and working with. So I love doing work in data-rich industries. And if you think back to the early 2000s, that was insurance, it was retail, they were capturing data. There was loyalty card data on everything. Nowadays, it's data everywhere. But back then, they were the people who had insight about. Amex knew more about how we were spending our money. Boots had loyalty card data on what you were buying in Boots along the way. And so there was an opportunity to generate insight from all of that. And I loved doing that. So I went quite deep in that area. And after a couple of years of working at Oliver Wyman back then, they offered me a transfer. So I went back to them and said, well, it's been really good fun. I've done the thing that I planned to do, which is learn about these industries. I've worked hard. Thank you very much. I'm planning to go back to medicine now. And they went, well, hold on there a minute, because we're growing. You've done really well on these projects, and we're growing the practice in the US. Would you consider a transfer to the States for this? And so I didn't expect that opportunity to arise. It sort of came a bit out of the blue. But I was in a position in my life where it was okay to make that transition and move to the US. They offered me a quite attractive package in terms of relocation and how it would work in practice. And I'd always wanted to live in the States for a little while. So when they offered me a chance to move to New York, I was like, yeah, definitely, let's make that happen. I'll come and do a year to 2 years in the US, and then I'll come back to medicine. But actually, that's what prompted me to have to stop, to rethink whether I could do clinical practice alongside working. Because obviously moving to the US, not having my US MLE, it wasn't feasible to do clinical practice in the US at the time. And so that was the decision point, really. And I moved to the States. I really enjoyed it. I actually did a 3-year stint building that practice out in the US, and then moved back to the UK to do my MBA. So that was quite fun. I think there is a level of excitement working in an emerging and new industry where you get to solve things and do things differently, that I really enjoyed. And using data to generate insight as a consultant was really fun in that respect.
So when you moved to the US, I guess that was the key moment, because you simply could not practice medicine. And was this something that you consciously thought about as a trade-off? Because I think about my own decision when I
Mm,
founded Patchwork with Anas.
yeah.
We incorporated the business in London, but I'd done all my training in the Northwest. And you'll know that, transferring from one region to another, there's so much friction in terms of, your policies, even your IT systems, which then naturally created just too much friction for me to continue locuming because I'd relocated as well to London. It wasn't something I'd consciously thought about as a hard trade-off. I always assumed that I could carry on practicing, but as I made that decision and followed through with it, it became simply impractical. So was that similar for yourself, or did you go into it eyes wide open, knowing that this may be the moment that you gave it all up?
Um, Probably more of the latter, actually. I think it was an active decision, but what it didn't
Mm.
feel like a very big or high risk decision at the time. So, and the reason for that is I had been locuming as well in the hospital I'd previously been working at. So I described that it was quite hard to do less than full time working at back then, but it was easy to do A&E shifts in the hospital I'd been working in, and I did orthopedics shifts as well. So I kept those going in parallel. And when you're doing that side by side, I think, you decide which you're finding more fun to go into in the morning.
Mm.
I was probably, they were differently fun, but I,
Yes.
I was okay giving one up for a while. And then I also had a conversation with a colleague at the time who said, well, do you think we're going to be short of doctors if you come back in 2 or 3 years' time? And the answer is no. And it isn't obvious that there's a route back in, but
Mm.
if you change the constraints a bit, there is a way back in, isn't there? So there were some things that I felt
Yes.
more comfortable practicing in than others. There, I actually went back to clinical practice again much later, and I didn't feel confident doing surgery or A&E at the time. But my educational supervisor went, well, the best supervised area of the hospital where you have lots of other colleagues around is the AMU. There's always a
Mm.
registrar
Mm.
around. There's always people to ask questions. If you're reintegrating, why don't you come and work as a trust grade in the AMU? And
Mm.
not doing it for the money. I'm not doing it for anything else, but for the experience to see how clinical practice has changed, in a supported environment. I think that there are always routes back in if you're willing to give a bit of your ego and, recognize that I'm not going to be the ultimate source of wisdom about the medicine that I'm practicing, and there'll be other people around me. I think that's doable. And my main takeaway from doing it was that the patients haven't changed. They're very much the same. And but I do think that there are things that we've done which meant that having had experience of it before, I probably got more satisfaction out of the job than some of my colleagues who were doing it kind of as a step on a treadmill.
So then, after a decade in consulting, what I find really fascinating is that you returned to the NHS into a senior operational and transformation role, which is highly unorthodox, I think, even in today's climate. Um, Talk me through how that came about.
That's really interesting. So a bit of that's me, but a bit of it's other people who are around, right? And the fact that they were um, interested to give me the job. So, in my consulting career, I've been an interim turnaround director at a big hospital organization or healthcare organization in the US for a short period. It's always a short period if it's turnaround in the US through Chapter 11. Um,
Mm.
so I had done a lot of relevant experience, but been out of the NHS at that point for 10 years, and I hadn't really done that much in the way of operational roles. The other part around it is the skill set required for the job that I did required being able to understand what was happening on the ground in multiple sites across the hospital, in a geographic area where you can't be present the whole time, where knowledgeable, how to interpret the data in addition to the interactions with your peers and colleagues is important. And so there were a set of skills which I had built outside of the NHS and outside of healthcare in the UK that were valuable and that the people who were recruiting found valuable. And also I was doing it at a time when that organization was looking to make some quite big changes. And that was, again, my skill set. So really interesting interview process. And I'm not it's one of those ones where UCLH was offered me the job, but I'm not sure that a small hospital would have done the same and might have perceived the risk of someone without deep NHS experience as being greater than the potential benefits of what I was bringing. And had I been applying for the wrong sort of jobs, it would have been a really depressing process, to be honest. But I found that was somewhere I could contribute and where my experience was valued. My experience outside the NHS was valued.
So you then went on and became Chief Innovation and Technology Officer in an NHS trust. And what I find fascinating is that this is not a typical role that you find in NHS organisations. So I'm wondering, what did that entail and how did you approach it?
You're right, it isn't something that I think exists in a lot of NHS trusts. It's something I think probably should. And I had various conversations along the way about what it would take to drive change in London with a number of chief execs around the patch. My own journey had been doing operations and doing change in operations and processes. We then embedded that in a technology system. So UCLH at the time moved from paper onto Epic as its main EHR, but actually that meant changing almost everything in the hospital. So what I took away from that is actually the skill set of a CIO, the Chief Information Officer of a hospital, is actually quite different to that of an IT director or those who've come through an IT path. And it's actually managing a whole set of risks that are business and operational risks in the hospital, as well as IT risks and working through. So had conversations along the way about what my role might be. And I joined the Royal Brompton as Chief Information Officer to start with, as a key bit of their transformation program. And then within the first 3 months, we reshaped my portfolio a little bit after I'd worked in there to drive the transformation forwards as well, which previously they'd had external support for and consultancy support for. So there was quite a cost saving in bringing it in-house as well. And so that's how that role came. But I genuinely believe that if we want to change the way we deliver healthcare, there's lots of incremental changes that we can make. But actually the opportunity now with technology and other innovations in data, genomics, and new pharmaceutical products coming along is actually to fundamentally change what our models of care are. And that kind of disruptive change needs us to think through, well, how do we do it? What's the right thing to do clinically and for the patients? And what do each member of a team do? But actually to embed that in operational processes that make that consistent, using IT and technology and do bits of it remotely and where it is. And then it's got to make financial sense, and we've got to manage the change through it in a safe way and make sure that the risk reporting works and works through. And that's the bit that I got involved in. And that's what we shaped up into a really coherent transformation program, working really closely with the medical director and really closely with the ops director. And there were a lot of difficult discussions in there about who does what and how we shape it up. What I really took away from having done the ops director role is that if you try and do the transformation and do the ops director role at the same time, when something's going wrong in theatres and you don't have enough staff there and work through the day-to-day pressures of running a hospital or service, it's quite hard to then do that at 8 o'clock in the morning and then step away and go at 11 o'clock into the transformation meeting and then go, oh yeah, and in 18 months time, we'll be doing this, and this. And you're like, my brain is still at my 8 o'clock moment where this person didn't turn up to clinic and is sick, and how am I going to cover, and what do we do?
I completely relate. As the former chief operating officer of Patchwork, you are firefighting Yeah, you're firefighting constantly, so it's a complete gear change from the here and now to the future planning, even if, you have the ambition and the appetite. So I I completely empathize.
So I was having this conversation with one of the hospitals here in South London recently, and
Mm.
one of their consultant leads was saying they're about to go through a process, or they're discussing whether it's a high risk thing to go to a process where 70% of their operational teams are doing ops and 30%
Mm.
do transformation, or whether they should have everybody do 70% of their jobs ops and 30% transformation. And that's an active conversation. And I don't know what the right answer to it is. Again, it's sort of, it depends on the context, but I always loved that bit
Yeah.
at the beginning of, don't know if you read Winnie, do you read Winnie the Pooh?
Um, I certainly have at
Oh,
some point.
yeah. Well, so I love the bit at the beginning of that where Winnie the Pooh's being dragged down the stairs and he keeps hitting his head on every step being pulled up and thinks, there must be a better way to do this. If only the banging would stop for long enough for me to think about what it is. That's where we are in healthcare, right? I mean, it's always felt like a good parallel because there are always more patients out there who we could see, who we could help. But how do we keep enough headspace to also be able to improve and change what we're doing? And I know some brilliant clinicians who are able to do that whilst doing their day job and making improvements
Mm.
as they go. And I also know clinicians who know that they do their best work with patients and will see the patients and would rather that somebody comes in and helps them. And, we can do either, can't we? I think patchwork actually helps with some of that stuff, which is one of the things that I've always appreciated about it.
Yes, definitely, definitely. I just want to go back and just touch upon what you described there about that role in the Royal Brompton. And I want to just draw attention to the fact that you actually joined as the CIO, the Chief Information Officer, which is a very conventional NHS role, but then you shaped it based on your expertise. And I think what you described there was that you also made a really compelling case for a cost saving because a lot of that transformation work was being done through an outsourced agency and you managed to package it all up. And I think that's such a brilliant example of people taking, having agency and shaping their careers according to their skill sets whilst also delivering what organizations need. It reminds me a lot of my conversations with Professor Ian Hennessy, who's the clinical director of innovation.
At Liverpool.
Yeah, exactly, at Alder Children's Hospital. And he describes similarly of taking a conventional role to start, identifying a gap, advocating for it, demonstrating the ROI, and then creating that role for himself. And it sounds very much like that's what you did at Royal Brompton. Is that fair to say?
Yeah, I think that is fair. What I would say about it is for that to work, I needed my chief exec to trust me to do a bunch of stuff. I asked for the office next door to the medical director and next door to the ops director and opposite the finance director, because that meant that we could reshape a chunk of this stuff. And then I think the other bit about it is almost none of it was saying, I'm not going to do the core bits of the job that you hired me for. It's all saying, I'll do all of that, I'll do it well, and I'll do more. And in that world, who's going, unless you're taking away from someone else, who's going to say no? And it's always in the spirit of helping. And the other thing I'd say about it is every time you take on more, you kind of don't get paid more for it in the NHS. To make it work, I was supported by a really good IT director who really helped me. And he's a CIO now at a large trust himself, and he's really good. So I think the other part of it is at each step, I hired people who were very different to me and had different skill sets, and who weren't afraid to tell me that they thought I was wrong sometimes in private, because that difference in opinion and being able to foster the kind of alternatives is really important. And I think that's what if I were to think through where I've seen opportunities for improvement in the NHS, I think that's one of my big ones, is that we tend to tend to value people who've had similar experience to us and who have worked in the NHS throughout their career. And I think we might do more by learning from others.
And now we come to present day. So you're the CEO of Health Innovation Network South London. So can you talk a bit more about how you made that decision to take the role and what excited you about it?
Yeah, so I had had a really good experience at UCLH trying to make change happen within an a big organization across multiple sites, and at the Brompton, where a lot of my focus had been on how do we support patients with quite specialist care needs across a very big geographic patch, because they actually serve a lot of patients outside the UK as well, who come to the UK for their treatment. And what was clearly the focus for the next 5 years that I've been doing now is around how do we deliver care across organizations and in the community, and how do we make things happen at a regional footprint. And as people were recruiting to as this role was available and we were thinking through what might the HIN do in the future, that was the focus. And that was the conversation that drew me in and that got me really excited about it, was how do we make change happen at scale using all the patients that are out there? How do we stop it being really incoherent and bitty? And one thing happening in one trust, something different happening down the road, and then the community services having to try and work out how to take patients back from two different organizations which are doing opposite things. So how does that join up? And that's what got me really excited about it. The opportunity to have impact at a regional scale in that kind of transformation journey. And I think the other bit is, it goes back to that thing we were saying at the top of the conversation, which is it's really easy to sit there and go, well, those people who do things at the regional, they don't really add that much value. You know, it's all happening at the trust level. I'm in the trust. I get to do it. They don't. The only way to solve that is to go and do it from the other side and bring your own experience to it. And I hope I'm doing that here, because sort of that's what it's all about, I think.
Yeah, just to deep dive that a bit more, because I think what's unique about yourself is that you've been on the front line in many different ways. You were a clinician and you were an executive trying to deliver this change. And now you've taken on the role to try and coordinate a system to adopt innovation and support innovators. So how have you tried to do this differently? And what are the kind of lessons for innovators that are, tuning in today?
Oof. So innovators is a really broad church. I'm really pleased you highlight the sort of different roles and the different environments. So I think there is something to take away from each of them. But innovators is quite a broad environment. So I think that there are some fantastic people within provider organizations, be they NHS or third sector or private sector, who look around and go, well, these are the building blocks I've got to work with. This is the IT system. This is the admin system. Now, what I want to do is X, how would I get that done with what's there? I think that they're innovators. They're entrepreneurs. They bring things in. If I think of like one of my colleagues who designed a foot and ankle service for their hospital in their region, they did it within a hospital. They're in every sense an entrepreneur. They do it within their own hospital and they work through it. So I think that skill set exists. And then some of those people, it makes sense to do it outside of an operating environment that exists. And then I think additional skills are needed in order to do that. And you may have had experience of this at Patchwork as well. It's sort of, well, then you remove some of the constraints, but you also then have to start building your own structures in those spaces, and that takes up some of your bandwidth. So my main advice is to think through what is it you're trying to achieve and what structures and environment around you will let you do that more quickly. And that's what I've spent a bit of time on. And that, frankly, that's why I love doing this within the NHS.
alongside your system leadership role, you're also an angel investor and advisor to startups as well. So, what was your motivation in I guess pursuing investment and advisory work, and what have you learned from it?
So I I don't actively invest as an angel at the moment, but I have a couple of companies that I have invested in that are still working. The reason I don't actively invest in healthcare in the UK is because in my current role, it would lead to
Mm,
potential conflicts with things I'm involved in choosing for. And I think that's the key thing that we have to watch out for.
mm,
But I have previously done that. And I've also been co-founder of a company along the way and worked through things. So I think my main takeaway is it's harder than most people think. So it's really easy to set up a company, and we hear all the stories of the ones that are successful and make money. But when you're an investor, you look at them and you go, had a conversation with this person. They looked great. They sounded great. They've got a good plan.
mm.
Yeah, I'll give them a 1 in 4 chance of being successful with that. Um, and I think that the thing that I took from the investment side of it is just how many good teams and good companies don't, with good ideas, don't quite make it to the big time. And we hear the success stories. We don't always hear some of the other parts. By the way, I would encourage all doctors to get involved in investment. And there are some really good EIS and SEIS schemes out there,
Mm,
which are very tax efficient to invest in, particularly those who are more senior and have got to the point where their pension, it's more efficient to do that than put more money into their pensions. So I think that that's really, really valuable. I think the other thing that it takes away is I'll be unguarded in my words here. I come across a few clinicians who look at it and go, oh, well, someone's going to make a lot of money out of this. And I'm not very comfortable with the fact that they're doing that. And I think the moment that you get into the investment world, you go, well, there are some returns to make, but the risk is also pretty high, and they are taking a big risk
mm.
in doing it. And depending on what your risk appetite is, if you have the appetite to do it, then by all means go and do it. But I suspect quite a lot of clinicians, if they spent more time investing, would go, I'd rather do the clinical job and let someone risk. So I think that's my the investor hat side of it.
That's a really good take, actually, because yes, you're absolutely right. Lots of clinicians have strong opinions. Um, and as we all work in the public sector, there can be certain animosity to those, taking the capitalist approach, as it were. But you're completely right. The moment you start investing, and seeing some of these journeys and how they pan out, you realize that it's bloody hard. And, and yet, like, I often think that actually clinicians could make the most of the tax incentives in the UK from angel investing, and also get a brilliant education into innovation along the way. I have a lot of people talk to me about clinician-led angel syndicates,
Mm.
which, if you can get past the conflict of interest, but that would be brilliant, because so many of these people want to have exposure to health tech and innovation, and can probably add a lot of value in terms of their own domain expertise. Um, so there's definitely something to that, I think.
I think that you are absolutely right, and I think that last bit is important to re-emphasize. So, in my world, I think that it will be very hard to find, or I think it's very important to be completely transparent about what your interests are in something, and particularly if you're involved in choosing products or services that you use. So um, that's why I've started by saying I'll try and keep the register of interests up to date on where we are and what's happening. And it's quite small now, which is quite helpful, because most of what I
Mm,
do is in public markets. But I think that that where I have seen people come a cropper, and it's happened recently, is that they were talking about a service and had not at the beginning said that they were a paid advisor. to the company that they were talking about. And I find that difficult. Well, I'll go further, actually. I don't think that's right for them to do it. I think it's fine for them to talk about it if they've said at the beginning of the conversation that they've seen this. They think it's such a good idea that they've, chosen to advise the company and work through, but they then can't be involved in choosing that company. There used to be an advert a long time ago from a guy who had bought a shaver company, and he went, "I used the shaver. I thought it was so good. It was Remington, I think, but I've used the shaver. I thought it was so good. I bought the company." I'm like, "Well, great, but you can't now spend public money on that company that you're representing."
Yeah,
that's
no, so true.
My own soapbox.
No, but I think that's fair. I mean, it's really hard. It's really tricky to navigate. So as I mentioned, the advantages is you can bring all this insight, you can learn all of this. You can basically have a front seat to how this innovation is building. But then on the other hand, because we all work in the public sector, we do, especially if you're a senior consultant, then there is that conflict of interest to navigate. I think in America, you have organizations like Scrub Capital, which is like a big angel syndicate of clinicians. And maybe in a private healthcare setting, it's a bit easier, trickier to replicate in public sector. But I think it's definitely a good idea worth someone to explore.
Yeah, and we've had a little look at it, but there don't seem to be that many people who are running angel syndicates who seem keen, because it's a more regulated service over here than in the US. It happens in Switzerland as well, so I've helped with the team that was setting one up with their equivalent of the GMC over there. But the bit that I would flag about it is that there is an opportunity to draw more capital into the healthcare industry in the UK by having doctors involved in that early stage work. And the reason I flag that is if you have a urology product and you have a bunch of investors who are not healthcare experts, the moment that they see that a urologist has looked at it as part of the syndicate and is investing in it and thinks it's a good idea, they're also willing to put their own money into it. And it makes it easier for those innovators who are starting their journey to raise capital from the angel pool in the UK. Because, I do a little bit, I do quite a bit of work with investors and have been this week at the moment. And I think one of the things that investors I talk to find difficult is if you're planning to sell a product in the UK and one of your main customers is the NHS, knowing whether the NHS is going to buy that product is quite a difficult thing to get your head around. And whether whether it's really solving a clinical need that's, seen either with amongst patients or doctors, that's hard to gauge in the UK. And I've seen angels being really influenced by what the clinicians they know and that are part of their network say. And so that's another reason I encourage doctors I know who are interested in investing to get involved in the angel scene.
Definitely. Watch the space. I'm sure someone is going to come up with an innovative and interesting,
And
model.
if anyone's thinking of doing it, then get in touch with me and I'm happy to have a chat. But
get in touch with me as well. Sounds very exciting.
I'd love to see more doctors and clinicians more broadly investing in it via the SEIS schemes that are out there, recognizing that they are much higher risk than most other investments that are out there.
Of course. So finally, what are you most looking forward to in the coming years? Like, what's next for you?
So I think we've been in a position where we're all ready for change at the moment and fairly, improvement in the way that we work. Lots of the things that I see happening in other industries, I think we're ready to do in healthcare now. I'm not sure that we've been able to do it over the last year to 2 years with all the changes that have been happening in governments, the wider world, in the NHS structures in the UK. So I'm actually really hopeful that the next year is going to be all about that the next year to 2 years. So this role, I think, is I hope is well placed to kind of help with some of that. But I would love to see us doing a lot more joined up work on digital. I'd love to see us do more work to make our own lives as clinicians better, and the way that we do training, the way that all our IT systems work on the HR side work better. I would also like to see a lot of the things that we've learned from other industries about non-clinical admin tasks and how to do those efficiently translate into healthcare environment. And I think all of that would then free us up with a bit of capacity. I described kind of the building blocks of what's out there, and that would then let us innovate our clinical practices at a pathway by pathway level or service by service level from those building blocks into something different and better for patients and for staff. And I'd love to see us do more on the evaluation of those changes. And so that's why, we spend quite a lot of time on evaluation at the end. So I think we're on that cusp of being able to make some big changes and improvements happen. I'll temper that slightly by saying I think we've been on that cusp for about a year and a half now. And so sort of cresting the hill's quite important. But I think it's going to get easier in the next year. And that's why I'm smiling and excited about the time when it isn't all roses, is it, at the moment? It's quite difficult to get things to happen sometimes.
Agreed. Well, that's a brilliant and optimistic message to wrap things up. So this is all the time we have for today. Thank you so much for joining me, Rishi. And for those listening, if you like what you hear and want to support the show, please do like and subscribe to us on Apple Podcasts, Spotify, YouTube, or whatever podcast platform you're currently listening to us on. It would mean a lot to me, and it would help us spread the message to others exploring alternative paths. Thank you for joining, and see you next time. Bye-bye.
See you.